Alrighty, so this is going to be the 3 o'clock recording for the mental health review because nobody showed up. I guess I'm going to be doing this alone. Love that for myself, but all these reviews are, just as I said I was going to be alone, somebody showed up. Hi, Andrea.
Hey,
Going to record. So what I'm planning on doing is I'm going to record these sessions in the 50-minute intervals. And I'm going to upload them to my YouTube channel and share like a general link to everybody so that everybody can watch these at 2 in the morning when they're studying, because I guess that's when people do things. But I only have 50 minutes, so it's going to be 3 50-minute sessions with like 5-minute breaks in between. So we're going to go over neurocog, substance abuse, and schizophrenia in this session, and then later tonight we're going to do the mood disorders, bipolar and depression. So what I'm going to do first is we're going to go ahead and focus this recording on the neurocog. So let me pull up our study guide. So a lot with our neurocognitive disorders, they're going to be a lot of our dementias and our deliriums. So dementia is basically about memory loss. So you can have dementia with any type of disorder, whether it be Alzheimer's. You can get dementia with your post-ops. One of the examples in one of the lectures that I was speaking about was that after ECT, a lot of our patients, they suffer from temporary dementia and that temporary memory loss that comes with it. But dementia, Alzheimer's, is a very, very common phenomenon. There's at least probably one relative in each family or at least one person that everybody knows that actually has a neurocognitive disorder. And that's such an important thing because as nurses, we have to know how to care for these people because a lot of times it is a mental health concern and a safety concern. A big thing with our neurocognitive disorder patients is safety. Because many of these patients, they wander, they sundown, they get aggressive. They don't know how to do certain little tasks. They can't remember a lot of things. So our concern with our nursing perspective is to make sure that they stay safe, whether it be in the environment that they're at or around other people. Okay. So we're going to go into drug-related disorders in the next session. So we're going to go ahead. One thing that we really need to know about is how to differentiate delirium, dementia, and Alzheimer's. So delirium is characterized by a disturbance in attention and awareness and change in cognition that develops rapidly over a short period of time. So delirium is going to be a lot with your clients that are, they might be having maybe a UTI. Maybe they're in the ICU. Maybe there's some type of change in their body that's precipitating a disturbance in cognition. Maybe it's medicated-induced delirium. But the key thing with delirium is that it goes fast. It starts fast. There's no gradual decline in memory or cognition. With delirium patients, they get very agitated, irritable, confused very quickly. And often with delirium, our course of action is to treat the cause. So, this goes into a little bit more about delirium. So remember, it's that change in disturbance over a short period of time. The symptoms will begin abruptly and usually will last 1 week or until the cause is eliminated. For example, if you have a patient that has delirium and they come in with a UTI that's causing that delirium, we can treat the UTI and you know what's going to happen? Their delirium might go away. It's based on treating the cause here. So some of our risk factors are infections, as I said, UTI, febrile illness, metabolic disorders, COPD, a lot of your medical surgical diagnoses, strokes, nutritional deficiency. If patients don't get enough of a certain enzyme or a certain vitamin or mineral, they can have states of confusion. Burns, you're losing a lot of fluid and electrolytes here that can precipitate delirium. Social isolation can be, especially a lot with our COVID patients, or COVID now, everybody's in social isolation. It can be causing delirium because they're not able to leave their house. Some people, they live in 4 doors, no windows. Of course, they're going to suffer for some delirium after a short period of time. Emotional distress, physical restraints, and ICU admission. But those who are a little bit of a higher risk are those who are older adults, people who are prone to falls, and people who have elder abuse. So if it's a little bit higher, it's because their body is not functioning as it used to be. Their immune system is low. They can't fight off infection, meaning they're more likely to get infection, they're more likely to be confused, and because of that, they're more likely to suffer from those delirium. Falls, of course, they can be confused, and it can happen like that. Of course, medication-induced, and our substances. Substance withdrawal and intoxication can mess up somebody's cognition very fast from the effects of the medication or the drug that they have. And of course, it can be secondary. Some of the signs and symptoms of delirium is they can't really sustain attention, they get distracted, they can't think and make decisions rationally, their thoughts are rambling, they're irrelevant, their speech switches from subject to subject, they can't reason, they might not be able to tell you who they are, where they're at, they might not be able to remember the year that they graduated high school, maybe the year that they got married. They might have illusions of things that aren't there, hallucinations. They might be seeing or hearing things that aren't there. They might not be able to sleep. They might be sleeping too much. There might be insomnia, an insomniac. They might have hypervigilance, stupor, vivid dreams, nightmares, hyperactivity, purposeless movements, catatonia, and they're going to be labile. So one thing we need to do with delirium to treat it is we need to treat the cause. Maybe we need to give them fluids. Maybe we need to give them a supplement of some sort. Maybe we need to give them an antibiotic. So we need to know about how to do that stuff so that we can treat the cause and hopefully get the person out of that state of delirium, because it can be reversed. Now, on the other hand, dementia and Alzheimer's, they're not always going to be able to be cured. A lot of times medications that affect patients who have dementia and Alzheimer's disease, they often are used to actually slow the disease process down, but not actually to cure it. And we're going to actually go into that a little bit later when we talk about some pharmaceuticals that we can use to slow down the process of delirium or dementia and Alzheimer's, like your cholinesterase inhibitors. So we'll go into that later. So dementia is a mental disorder involving functional decline in multiple cognitive areas, like your memory, but it can also be behavioral and psychological symptoms. A lot of times, patients who go through dementia and Alzheimer's, they're going to have problems first being able to do those higher processing things, like, for example, being able to cook or balance their checkbook. But then again, we don't really balance our checkbooks in person now. We all do it. It's all more automated. But they may not know how to do simple addition and subtraction. Okay, so Alzheimer's originates in the brain. But dementia, it can be a function of many things. All of our psych disorders, they're going to be biological, social, and psychological concerns altogether. So we don't know exactly what might participate in disorder, but what we do know is that it might be a combination of many factors. So Alzheimer's stages are going to be very important on this test. So we need to know exactly what's going to be mild Alzheimer's, or it might be moderate Alzheimer's, or it might be severe Alzheimer's. We want to know what might be severe Alzheimer's. And a lot of our nursing interventions are going to correlate with what occur in these stages. Because the one thing we want to do with Alzheimer's patients or somebody with an NCD is keep them safe. So in stage 1 of Alzheimer's, you're not really going to see a lot of symptoms, but we may see maybe some, like, a little bit of forgetfulness. So you might see there's no decline in memory, but in the brain there might be those changes occurring. The only way we can see that is with a PET scan. Stage 2, you're going to have that forgetfulness. So maybe the person forgets where their phone is. Maybe they forget where the TV remote is. A concern with a lot of our patients who have cognition concerns is forgetting to turn off the stove. Because, or like forgetting, I have a candle right next to me. If I had a cognitive disorder, I may forget to blow out that candle. That's a safety risk. But in stage 2, they're going to have that mild forgetfulness. And the person may know that they have this. And they may not realize. They may realize it and be ashamed about it. One thing that they might do in stage 2 is they may try and rationalize their forgetfulness with other things. They might compensate as well. They may decide to excel at other things. But when they ask how to do certain things, they're not going to know. So most of the times people who have stage 2 Alzheimer's disease, they're going to have symptoms that they might not notice by others, but they're going to still be able to live their life. So stage 3, we're going to have a mild cognitive decline. So there's going to be changes in thinking that interfere with work performance. Maybe, for example, you're a nurse. You might be an older age nurse. Maybe one day at work, you absolutely know how to do your physical assessment. You know how to insert an IV, but you come into work this day and you forget how to do every single thing. You might have a hard time getting along with your coworkers. You may have even got lost on the way to the hospital to go to work. You may not know certain names of procedures. You may not know your names of your coworkers. And the concern is it might be noticeable to others. The patient may not be able to plan or organize their day. They may have unstructured environments with them, which is another important nursing intervention. We have to provide structure for patients that have an NCD, because often they're going to want to do whatever they want to do, and they're not going to stay. They need that structure in their life to be able to function. Sorry. Stage 4, you're going to have mild to moderate decline. So they're going to forget major events. Maybe they'll forget their daughter's birthday. They may not be able to go to the grocery store. They may not be able to understand what COVID is. However, in stage 4, they're going to have that confabulation occur, which is where the client makes up stories when questioned about events or activities they do not remember. For example, remember if one was asked about their favorite childhood activity, they may make something up totally relevant to their life, as they cannot remember their childhood that well. Maybe they're a big soccer player, and they didn't like roller coasters. Well, maybe they'll make up a story about roller coasters when asked about if they played soccer. Even though they played soccer for 18 years, they may put in something else into that position. And that is what confabulation is. They make up stories when asking about events or activities they don't know. Stage 5 is where you have that moderate cognitive decline. Here's when they lose the ability to do some of their activities of daily living. Maybe they forget how to tie their shoes. Maybe they forget how to zip up a zipper. Maybe they forget how to wash their hair. So at this point, they probably are going to have a lot of frustration and withdrawal in them because they're not able to do things. They may not remember their addresses. They may not remember their phone number. A concern with people in moderate cognitive decline is that they'll forget to call 911 if there's a real emergency. Maybe they leave the stove on. Maybe they forget to turn off the stove after they boil a pot of pasta. And now they burn their hand. They're not going to know what the number is for EMS services, and that's a problem. Again, with safety in that. So, stage 6 is where you have that moderate and cognitive decline. So they're not going to remember basically any of their names. They're going to not know where they are. They might not know the month of the year. They're not going to know how to do EDLs. They might have delusions. They're going to have incontinence. They might be insomniacs. They might have trouble sleeping. They might have that wandering. They might have agitation and aggression when confronted about it. They may not be able to communicate with others. They're going to lose that language or the ability to, I think it's called apraxia. They're not going to be able to understand or communicate with other people. So at stage 5 and stage 6, usually they're going to be placed, say, in a assisted living facility to help with those activities of daily living. But it's also going to be probably for safety and structure. Because if you leave a person that has dementia or Alzheimer's alone, they could be in a lot of danger. You don't know what could happen to them. They may forget that there's an electrical cord and shock themselves. They may, again, with the stove, they might leave the stove on. And next thing you know, there's a fire going on in the house. Or they hurt themselves and they can't call 911. And that's a problem. So a lot of institutions, everybody's probably heard of sundowning by now. So it's where the patient decides that they get aggressive, they have delusions, agitation, and disorientation that due to a change in the environmental structure, usually occurs in the late afternoon or evening. The patient will decide to wander, they're going to get aggressive, and it's all based on that because the environment is changing. Maybe it's dark outside. Maybe everybody's going to bed. Maybe they don't want to go to bed. Maybe they don't want to go to bed, but they can't express it. So this is where sundowning is going to occur. So a lot about sundowning is going to be about your staff safety, and trying to get that client to cooperate with you. Although you can't force them to, a lot of our sundowners, they can get aggressive and can harm others, and that's a big concern from us. So my example here is that a client might hit or start to kick staff after dinner because they may not remember what their names are. Because I know that a lot of times shift change will happen near dinner time, and then the client, they'll get a new nurse, and they won't realize what their name is, and they'll get confused. They'll be oh, I had Nurse Ashley all day, and now I'm going to have Nurse Ryan. But then they're going to be Nurse Ryan walks into the room to get bedside to go give her evening meds, and they're going to be the patient Gloria, she's going to be you're not Ashley, you're not my granddaughter, and they're going to get very aggressive, and it's all because of that change in environmental stimuli, and that's what sundowning is. So some things to prevent sundowning is you can always have that two-person approach. And once the patient calms, and you want to make sure you maintain safety of the patient, make sure that they're in an environment where they don't have anything that can harm themselves. Maybe they want to put them in a private room close to the nurse's station. A lot of that observation and using therapeutic communication would be beneficial here. However, we also want to maintain structure and focus. But if the client's aggressive, they're not going to be able to focus. They're not going to be able to learn anything. So we want to make sure that we wait until they calm down to really do anything. If you see that they're having those psychological delusions, maybe Haldol, maybe a benzo would be good in this situation to decrease the level of aggressiveness and to decrease psychological manifestations. Alrighty, and then severe is usually that end stage deterioration. The individual can't recognize their family members. They're not going to be able to get out of bed. They're not going to remember how to walk. They're not going to remember how to talk. They may suffer from ulcers on their butts and contractures because they're not getting out of bed. They're going to be incontinent. They're basically not going to be able to do much anything. Okay, we went over delirium already. I just really wanted to go with the stages because those are going to definitely be on the test. We're good at time. So, dementia can be caused by many different things. However, Alzheimer's is basically going to be caused by something in the brain. So there's going to be atrophy of those neurons that are in the brain. It's going to be slow and insidious, and the course is going to be progressive and deteriorating. It can often be from different structures in the brain, different ventricles in the brain. There's tangles and plaques. Those biomarkers are going to be damaged. There's going to be neuron death. They're going to have low metabolite levels. These might be when you see somebody in stage 1 or stage 2. But when you get down to stage 5, 6, or 7, often the brain's going to be very diminished. You're going to have a decrease in these neurotransmitters. Remember, the dopamine theory is going to be in there. That because of that, I think that there's decreased amounts of neurons of dopamine. But let me see if I can pull that up on the Quizlet that I made. Oh yeah, if you haven't checked out my Quizlets, go for it. But I know I put this on there. Sorry. I don't know if I put this on here or not. Anyways, let me research this. I might have put it on a different one. Oh wait, that's with schizophrenia. Oops. I'm done. Okay, don't worry about it. Don't worry about everything I said. But you can also have lobe degeneration, genetic causes, signs and symptoms of behavioral. We went over a lot of that already. It's going to correlate with those stages. Lewy body disease, there's different types of dementias caused by different parts of the brain. So remember, Lewy body disease is where there's Lewy bodies seen in the cortex and the brainstem, causing ACH, acetylcholinesterase reduction, and causing those Lewy bodies to be present. Those are just some signs and symptoms of the disorder. They're going to have hallucinations, Parkinsonians, because of the acetylcholinesterase, depression, delusions. So vascular disease, dementia, is going to be very also common as well. You might actually see these a lot in patients that have blood disorders or heart disease. Because a lot of times, if there's blood clots in the brain, and if there's those the vessels in the brain get clogged because of the person's maybe having too much sodium or high cholesterol, there's blood vessels in your brain. And if those can't function, then the brain can't get the blood supply that it needs for neurons to function. And because of that chronic use, they're going to have death of those nerve cells. Because those nerve cells aren't getting blood, ischemia can occur, and of course, necrosis. So when blood flow is impaired to the brain, deterioration can occur because those brain cells are not getting blood. It can be in the large vessels or microvascular vessels. It depends on the type, extent, and location. So it can be very fast, or it can be very decline. Remember high blood pressure and strokes. Remember, small strokes may be apparent that destroy parts of the brain. Remember silent strokes, because once a stroke happens, no blood flow can get to the brain, no oxygen can get to the brain tissues, neurons can't function. And because of that, brain tissue is going to die, so is functioning. And that's how dementia is going to occur. What else is there? TBIs, because there's an impact to the head, movement and displacement of the brain, loss of consciousness, amnesia, they're going to have those neurological signs, and they're going to have damage of the brain. And because of this, they're going to have a lot of amnesia. They might be able to not do certain things. They're not going to remember because the brain is moved around in the head. There's trauma to the brain. There might be damage to the brain tissue. And that's why TBIs are so important to take care of, because dementia can occur. Okay, substance abuse, OD abuse. If somebody overdoses, they can get into a state of dementia because of the substance intoxication. HIV infection. So there's a theory that HIV can lead to immune dysfunction, brain infections, might be early stages, can cause changes in the normal psychological presentation, but it's a theory that it might be able to cause this. Prion disease. So the infectious agents called prions, they cause insidious, so we don't know what causes it, and progression, so they're going to have those dementia progressions. So often we'll take a CSF sample. The course of prion disease is going to be very rapid, with death usually occurring in 2 years. So if you ever heard of Creutzfeldt-Jacobs disease, this is basically what it is. A lot of our patients with Creutzfeldt-Jacobs disease have excessive prions in their brain, causing their decline. So a lot of times people with CJG are going to deteriorate very, 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 very fast, often until they're bedbound, and they're probably going to die. So it's kind of like a death sentence. It's a really sad disorder. But however, it's going to cause those symptoms of dementia, problems with coordination, movements disturbances. They're not going to remember things. Eventually, it's going to cause that severe dementia, basically. Parkinson's disease. Remember, there's going to be decreased dopamine activity, a lot of those involuntary muscle movements and tremors. It can occur in people with dementia. Huntington's disease is going to be from genetics. So often, if you have Huntington's disease dementia, it's going to be because of it's going to be a genetic onset. This is usually what happens with like your kind of like adolescent, young adult dementia. However, it will last a long time, but the patient's going to usually pass away. But there is going to be those twitching in the limbs, cognitive changes, depression, and apathy. It's going to be profound cognitive impairment, and that's why they usually pass away. And of course, secondary to other medical conditions, multiple reasons, of course, and genetic history. Because genetic history is going to always put you at that risk. So if your grandpa had dementia and passed away from that, or they had Alzheimer's disease, there's a chance that you and your parents may actually have the disorder too. So, but you won't know that. I mean, you can do genetic testing, but I mean, those are just some more signs and symptoms. Remember, they're going to not have abstract thinking. They're not going to be able to do any, they might have, not able to make decisions. They may not be able to do certain things. They may not be able to speak. They might not be able to name an object. They can't communicate. They're going to have personality changes, maybe once that they were so active, but now they might feel embarrassed or guilty, and they might be isolated because they're afraid of that guilt. They're going to have, they might be paranoid. They might have fear. They may not be able to do their ADLs, movements. They may not be able to feed themselves or get fluids or go to the bathroom. So aphasia is inability to speak or communicate needs. That's something that many of our moderate to severe dementia patients have, because they may not be able to communicate their needs because they can't do it. They don't know how to do it. They lose that ability to do it. And then apraxia is inability to carry out motor activities despite motor function, or inability to use objects or properly. They're not going to remember how to use certain objects. They may not be able to know how to use a fork to feed themselves. Even though they have two hands and they can move, they're not going to remember how to do that. And that's why they're not able to feed themselves. And because of that, they're going to be lacking nutrition. So the first thing that we need to do when we see somebody who has a neurocognitive disorder is do a full assessment. You can either get it from the patient or the family. A lot of times they may need the family to help get additional information because the patient can't remember it. You have to know when they started, what kinds of mood swings they have, personality changes, cognitive changes, what they can and can't do. Can they speak? Do they know who themselves are? What kinds of social behaviors do they have? What kinds of meds do they take? Do they use substances? What kinds of toxins have they been exposed to? And then any med-surg conditions should we know about? Remember, you want to make sure that you do a complete neurological exam, muscle strength exam. You want to assess for abuse, neglect, vision, hearing. Do your mental status exam. Remember your mood and affect, your dress, that kind of stuff. You can do lab tests to determine it further. You can do blood and urine, liver studies, glucose tests. These kind of like rule out a lot of different causes. You can do diagnostic procedures. The main two diagnostic procedures that you might do here when diagnosing one with a neurocognitive disorder would be a CT scan to see brain deterioration, MRI to show tissue atrophy, or a PET scan to show that metabolic activity. So now we get to nursing care. So some of our nursing kind of like focuses here are going to be risk for trauma and risk for injury because the patient may not be able to do certain things. Remember, you always want to make sure that you have a easy environment. Make sure that they have pathways, bed in lowest positions. Remember, they may need to have one of those wandering armbands on. If they go out, may not need to have a room near the nurse station for observation. Remember to keep away those hazardous activities or articles like razors, toothbrushes, forks, knives, and always have somebody in the room to stay with the patient while they're using them. Assist with ambulation if they cannot walk by themselves yet. They may need to have a canter walker, may need a wheelchair. We want to make sure that we teach them to use hand railing if they can, and then make sure they call for assistance. A lot of our patients who have a neurocognitive disorder, they may not be able to call for assistance. So we need to make sure that we're on top of checking them and doing rounds. Always be calm. Always talk to them in a calm but firm voice, and never force them to do anything. Give them a safe environment. Walk with them and always redirect them if they're wandering. Have a structured schedule and have a strict feeding and toileting schedule. Remember your purposeful hourly rounding. Even with your psych patients, you need to do your rounds. But remember to never expect that you're going to come and do them. Make sure you do them. Make sure that they don't have access to outdoor exits if possible. A lot of this is about disturbed perception. They may not be able to remember certain things. Remember that you can use clocks to help them determine easy to read. Remember that they can have personal items if they're allowed to by the provider. Remember, a lot of our psychiatric patients, they're not allowed to have their belongings without a doctor's order. So you can provide them maybe with radio, television, TV shows that they like. Maybe allow them to have photographs. Always have that consistency of staff members and caregivers, because a lot of our patients with a neurocognitive disorder that are in a facility, they're not going to remember who cared for them the night before. And also, we want to make sure that we avoid that that aggression and that agitation. They may not remember the person that cared for them the night before. Maybe they wanted a certain caregiver one night and they didn't get it. So we want to make sure that we have consistency of staff so that the patient can feel secure and that we don't have altercations. Remember, always minimize focus, always redirect and reorient to reality. Never argue with a patient, but always focus in. Remember your therapeutic techniques, they're going to be on there. Never ignore presence of hallucination. Remember, with hallucinations, you need to ask the client, what do they see? What do they hear? What's going on? Ask them if the hallucination is going to harm them, and then tell them that you don't say anything and reorient them back and maybe distract them if possible. Once you realize and tell them that there's no hallucination there. Assess for medication side effects. Remember, they need to have working ear and eyeglasses. Always make sure the patient is safe. Always observe them. Distractions can occur on distractions, and always focus on reality. Impaired verbal communication. You can use gestures, but you need to use a combination of gestures and movement and like words. Remember, simple and short sentences with these patients, because they're often not going to be able to understand long and strenuous words. Remember, ask one question at a time and give patience to the patient, because they may not be able to answer right away. Always remain calm if they become aggressive. Self-care deficit. Remember, you can assist them if needed. Always have a structured schedule of ADLs. Okay, so therapeutic procedures. You can give certain medications for delirium. Best to not give an antipsychotic with delirium. You're going to want to treat the cause really here. Neurocognitive disorders, you may need to use those cholinesterase inhibitors, antipsychotics, benzos, sedatives. You just kind of have to use the medication to treat it. Let's go over cholinesterase inhibitors. So remember your donepezil, rivastigmine, galantamine. Remember that these medications prevent block ACH and from entering the neuron and increase at receptor sites. It only slows the diseases, Alzheimer's and dementia, but doesn't treat them, like cure them. Remember your cholinergic side effects. Low heart rate. Remember to always monitor vitals and oxygen level. And if they have those severe cholinergic effects, you can use atropine. Remember, you want to teach the client and the family to report those intolerable effects. Remember, you may need help with scheduling of the medication. Allow a caregiver to help with that. Remember to always take the med as prescribed and to never stop. And then teach that it will not cure but only slow down. It's effective when muscle strength is increased and cognition is improved. And that the disease is slowed down. Memantine, same thing really, except without those cholinesterase side effects. One thing is safety. Remember, educate the family, because the family is going to be the one that's going to be taking care of the client at home. Remember, they need a safe environment, no scatter rugs, door locks are needed, lock water heater, need good lighting, handrails, low mattresses, no clutter, lock cupboards, non-slip mats, need a schedule. Remember, they may not need to, don't allow them to use the oven. Always encourage expressing feelings. And then these are the people that you really should be involved with care. And remember that they can become unsafe, they can wander, and then they can also die as well. Alrighty. And that was actually going to be on, those are going to be on neurocognitive disorders. So I'm going to stop sharing, and that is going to be the recording for the neurocognitive disorders. So you're welcome to join me for the next session on substance abuse disorders. That's going to start around 4-ish. Okay?
Okay, great.